Hey, good afternoon. I tell everybody I'm a recovering radiologist, but I've really been doing interventional pain for about 20 years. It was tough when I got in because there weren't any of these meetings, so I kind of worked my way up through the ranks. And to my good fortune, I had a lot of the people here in the front row, Aaron and Dr. Rax and Dr. Ector. These guys were my mentors. So I want to thank you all, and Dr. Rosenthal. So exosomes have really been a hot topic within the last 5 years or so. So 95% of all the papers you'll read about exosomes were written in the last 5 years. Exosomes are basically the paracrine or trophic secretions of any cell, but specifically today we're going to talk about MSC exosomes, mesenchymal cell or medicinal signaling cell exosomes. I saw this picture, about a year and a half ago, and I was really interested because this was a stage 2 burn at day 0. And something that should take, 2-3 weeks with scarring, especially in Afro-American, didn't look like that. And that was after topical application. So it kind of piqued my interest. Arnold Kaplan covered this, that these are all medicinal signaling cells at this point. So I want to take you back for a second. But 100 years ago, the first, I don't know how many of them have won, but the first psychiatrist to win the Nobel Prize was Julius Wagner Jurek. And he had a really crazy idea. He said if we took people who had syphilis, and they had neurosyphilis, and we hit them with malaria, and we take them within an inch of their death, and they're about to go, and then we rescue them with a little quinine, they may come out of it totally normal, totally sane, totally lucid. And about 10 years after that, they give him the Nobel Prize for his use of hyperpyrexia. So penicillin comes along, and by 1942, I will tell you that nobody's getting malaria for syphilis anymore. So I think that the playing field is changing. What I mean is that for years, we've been promoting take stem cells from fat, take stem cells from bone marrow. And maybe we should be keying in more on the trophic effectors or the paracrine secretions, like Dr. Kaplan said this morning. Now this is first stage stuff. First stage is basically taking the exosomes, I call it God's broth that is basically rebottled, because we're not changing the expression of one specific growth factor over another. The next stage is what we talked about with some of the bioengineering, where we start upregulating some of the specific growth factors, maybe some more TGF-beta-3 for it to be more anti-inflammatory, but we'll get into all that. So what are MSC exosomes? They're vesicles or microvesicles that come from endosomal budding or from budding along the external membrane. So with that, they're conserving many of the proteins in the membrane from the parent MSCs. And that's kind of important because we used to think that they didn't home. Home means that they have a certain attraction to areas of inflammation, and they may use some cell-cell interactions to get there and stay there. But in fact, we've seen now that within spinal cord and with an acute kidney injury, some of these exosomes will locate to those areas. So it must be that there are still some cell-cell interactions present. So what are some possible medical conditions? Well, there's a litany of them. We've covered a lot of the musculoskeletal. I'm really interested in a lot of the autoimmune, a lot of the neurodegenerative, but certainly there's indications for burns and scars and heart disease and lung disease, liver, kidney. I'm using it in my own practice for inflammatory bowel. I have a patient with autism where I'm using this intranasally through the cribriform plate. Certainly for neuropathies, I use it for ED, urinary incontinence, and we're talking about some of the other areas of neuropathic pain as well. And there's a myriad of aesthetic applications which I don't use it for. So about 100 years ago, this stuff started. This is called parabiosis. If you take two rats, one's an old rat and one's a young rat, and you shave them and you skin them a little bit and then sew them together, and you let them run around for a month or two, and then you euthanize them, the old rat will look young, and the young rat will similarly look old. So on the West Coast, they're making money on this. So there's one group called Alkahest, where they're treating Alzheimer's with plasma of 20-somethings. And there's another group, Ambrosia, doing the same thing, just giving you a 2-liter bag of plasma if you just want to feel younger. Now, why does that stuff work? Are there any stem cells in your peripheral circulation? Not a lot, right? We learned today that they're parasites and they live on the vessel walls. So what do you think's in our plasma? Little exosomes. All right, so when we look at exosomal studies, a lot of the stuff that we gain and a lot of the information that we learn comes from translational medicine. That means with translational medicine, we look at animals and we say, hey, how can we use that in people? So we've seen a couple of different things with translational studies, and we've seen that the exosomes, or the secretion products of the MSCs, recapitulate what the MSCs do. So what are some key advantages to exosomes? Well, first of all, they can travel without clumping. They can cross the blood-brain barrier. We can use them locally or peripherally. And remember, with the MSC exosomes, there's no DNA and there's no cell membranes, the larger cell membranes, so they don't get rejected, and you can't cause cancer with them, right? I can't give you messenger RNA and you're going to cause reverse transcriptase and splice it into your DNA. You don't have that, nor do I. So they do home, as I said before. They're not perceived as foreign, and they will not be kicked out by your immune system. No first-pass lung effect. We know MSCs get trapped in the lung. They're not going to transdifferentiate into malignant cells. They're easy to administer, store, and freeze, and we can control the dose. How do they work? Well, they influence the growth of target cells. They influence phenotypes. So we know with respect to macrophages, if you remember nothing else, M1 macrophages are bad. They're hyperinflammatory. M2s are good when you're dealing with inflammatory problems. They can prevent cell apoptosis. They promote regeneration. They're immunomodulatory without being immunosuppressive. They're anti-inflammatory and anti-fibrotic. And we look at the milieu of what they produce. There's a lot of different growth factors. So earlier, Dr. Kalani was talking about how it's patentable with the 351s because they're trying to wrap intellectual property around one growth factor, one interleukin, one cytokine, right? So we want VEGF because that'll promote blood vessel flow. Well, if you look at it and you Google VEGF, VEGF does 60 other things besides make blood vessels grow. And the same is true with stem cell factor, BMP, which produces growth in bones. Interleukin-1 receptor antagonist takes out an inflammatory interleukin-1. Interleukin-10 is significantly anti-inflammatory. So is TGF-beta-3, that was in there. And so are some of these other things that bind some of these inflammatory structures. But the idea is, with an MSC exosome, you're getting the whole milieu, not just one. Some of the immunological effects, they downregulate Th1 and Th17. They promote Treg cells. They upregulate M2 macrophages at the expense of M1 macrophages. And we looked at that scar earlier. One of the key things they do is they increase the ratio of type 3 collagen to type 1, and they increase the ratio of TGF-beta-3 to TGF-beta-1. If you have a burn and you put PRP or amniotic fluid on a burn, it'll close, but it's going to scar because of the TGF-beta-1. The TGF-beta-3 is very rich in MSC exosomes. There is a myriad of aesthetic protocols that I don't want to get into too much. I will show you, this is a young man that came into my practice. He has a spinal cord injury. He wouldn't let me treat his spinal cord until his hair got better. So next week he's coming for me to do some intrathecals. We'll get into that. I use this stuff in many different musculoskeletal applications. Dr. Chang gave a lovely, lovely talk of PRP. I use it in conjunction with PRP. I use PRP as a scaffold, plus I make use of many of the growth factors. PRP and exosomes can be used together with these ultrasound-guided procedures. I do use them in the discs. Certain trophic activity factors within the joint space can affect, these are all precursor cells, and we've talked about resident stem cells, and most of the work that we're doing, whether you harvest MSCs or you use the exosomal derivative of MSCs, I will tell you that you're upregulating your own body's resident MSCs and sort of turning them on. And just within the joint, you've got chondrocytes, progenitor cells, cartilage progenitor cells, synovial progenitor cells, osteoblastic progenitor cells. Just in the joints, you're rich in all these progenitor cells. So some of the trophic activities relevant to MSK therapy, angiogenesis, neurogenesis, osteogenesis, even musculogenesis. And certainly there are chondroprotective and anti-inflammatory. So just a brief bit on the disc, because I know Dr. Dewan is going to go into some of your disc disease problems. So what things go wrong as we get older? Well, we start losing the long chain proteoglycans like aggrecan and vesican, and we start getting shorter chain aminoglycans or proteoglycans that contain less fluid. So you desiccate. You get more type 1 collagen. The homeostatic levels of anabolism and catabolism are no longer equal, and you start degrading your discs and your inflammatory mediators and your metalloproteinases and all of those. That soup gets big. Pro-inflammatory cytokines sensitize the outer third of the annulus. You get damage to the end plates. You get Schmorl's nodes. Some of you smoke. We get obese. Our vessels go bad. There's decreased O2, decreased nutrition, and increased acidity in our discs. We've done studies over the years. It doesn't pay to just be on bed rest, right? So some dynamic loading is okay. Doesn't mean we should be squatting 500 pounds every day, but bed rest is not the answer. So with respect to disc disease, I choose regenerative therapy. If I can, many of you heard me speak this morning about endoscopic spine surgery. But if given the choice, and there's internal disc disruption, an annular tear, degenerative disc disease, small protrusions, acute Schmorl's nodes, this is the perfect way to play. So what makes sense regeneratively? Well, a scaffold makes sense. But in that scaffold, cells have to be able to move in and move out. So I like PRP for that reason. Now, what else makes sense? Well, certain anti-catabolic factors that bind metalloproteinases, that bind interleukin 1, that bind TNF-alpha, that makes sense. And certain things that are anabolic and cause cell growth, those make sense. And we don't want to have any of those catabolic factors. But if you look at this chart, the stars are seen in MSCs and exosome children of MSCs. It's a 23-year-old D1 basketball player that missed the draft. On the left is the pre-op images. On the right, you're going to notice here, and I got to draw your attention to it. These are areas of what we would think increased fluid. So, I'm thinking to myself, wow, did I give this guy a discitis? Is this some kind of an inflammatory change? But I took his ESR and his CRP, dead normal, lower than normal. And right about here, he got picked up by an MBA team. So no pain with that. So you won't see that in the books, but that is actually regenerative medicine effect of what happens in the vertebral bodies adjacent to some of these disc injections, and I've seen it again. So CNS disease, neurodegenerative disease, this is the last section I'm going to take your time with. There's a lot of spinal cord injuries every year, and there's a lot of brain injuries, and we're going to talk a little about neurodegenerative problems. But most of the major problems with the traumatic incidents, traumatic brain injuries, spinal cord injuries, strokes, it occurs in the gray matter. That's the initial acute problem. Most of the therapeutics are directed against the white matter problems, and those are the secondary problems of inflammation, apoptosis. And these things happen within seconds to minutes afterwards. And the cascade of inflammatory reactions relies a lot upon the immune cells. So neutrophils, that's your innate immune system, they come in right away and they remove debris, but they secrete a bunch of proteolytic enzymes. Then the macrophages come in. And we have two different flavors of names of macrophages. We've got the microglia macrophages that live within the CNS, and then we got the monocytes macrophages that migrate in once the blood-brain barrier breaks down. And they release pro-inflammatory cytokines. And finally, you get the upregulated T cells. The T helper cells upregulate your killer cells and your B cells, and that's part of your adaptive immunity that kicks in. So when you're dealing with acute injuries, if you have an injury in your foot, and you have inflammatory changes in your ankle, you twisted your ankle, your peripheral system can get rid of the inflammation, heal, and then go on with itself. You can't do that in the CNS. We're not built to deal with the inflammation. So even though your injury may start today, you can look 5 years hence, and you're still going to have inflammatory changes and problems. And part of the problem is that you're upregulating your M1 macrophages. If you have MS, you're actually switching, that myelin basic protein is switching your M2 back to an M1 macrophage. The exosomes and MSCs downregulate those M1 macrophages to M2s. The other thing that happens when you have injury, you get a paradox. You get a situation where immunosuppression occurs A lot of these people get septic and get infected. And in other people, when your body sees the artificial antigens, all of a sudden now you get an upregulation in your immune system. So you get the paradox of immune suppression with autoimmunity. You know, this is one of the other reasons that your discs hurt. Your immune system is never supposed to see the nuclear material within your disc. Just like you don't see the testes, just like you don't see the lens of your eye. Your immune system forms after these things are walled off. So just like that, if your blood-brain barrier breaks down, all these cells see your antigens in your CNS as foreign, and they start attacking them. One of the things that happens, by the way, with the microglia is that you may see activated microglia, M1s, far away from the incident injury. So that may actually be one of the reasons that you develop the neuropathic pain after these types of injuries. So remember from this slide that basically both autoimmunity and immune suppression can coexist. And autoimmune disease is a bad predictor, by the way, for brain disease in general. It increases your risk of dementia. And the only one on the list that doesn't increase your risk is the rheumatoid arthritis, and that may be because we're partially treating it with the NSAIDs. So, this is a very important slide, and I came to this slide after researching what happens. Dr. Chang said an excellent thing today. He said when we're dealing with biologics, most biologics take time, right? 6 weeks to 12 weeks and far beyond. Except sometimes when I'm treating some of these patients, things happen that I wasn't able to make sense of. I was treating a patient with Alzheimer's, and I did an intrathecal injection, which I'll show you in a minute, and I did a little IV exosomes. And 10 days later, his wife calls me and says, Doug, you never guess where Anthony was. I said, where's Anthony? She goes, he's downstairs looking in his safe. I said, is that unusual? She said, yeah, 16 years ago when he had a stroke, he forgot the combination. And then he started doing word puzzles. And then my Parkinson's patient came in 3 weeks later, happy, way decreased tremors, 40% decrease on meds, 2 to 3 weeks after I injected him. And he hadn't been able to sleep for 14 months because of the fact that he was getting spasms in the middle of the night. And all of a sudden, 4 or 5 days after the intrathecal injection, his spasms at night stopped, miraculously, right? Well, it seems that when you upregulate your T cells eat up the amino acids that are necessary for your neurotransmitters. And there's only a set pool of these amino acids. So if you get T helper cell activation, you actually downregulate the amount of amino acids that are available for making your amino acids that are necessary for your neurotransmitters. So the T cells are essential providers of adaptive immunity. That's true. But as they monopolize the systemic pool of amino acids, they do so at the cost of diminished brain function. I said maybe that's one of the reasons that this is happening. Some potential reasons that this is very good, we're utilizing the neurogenic niche. So there are resident stem cells even in your CNS. And we know that there is a need for new therapies. You know, in Parkinson's, we don't just lose areas of the substantia nigra. There are other areas where you get reduction of proliferating cells in the subgranular zone, subventricular zone. You get areas of protein deposition, alpha-synuclein, and there's decreased neurogenesis both in stroke, and we know that both MSCs and exosomes can increase these cells. If you look in the bottom there, these are basically the neurogenic regions where you have niches of stem cells. In the subgranular zone, the subventricular zone, and the spinal cord. And we give people with Parkinson's DOPA, but DOPA is not fixing what's happening in the substantia nigra, nor is it helping any of the other neurotransmitters, and many of these people with Parkinson's are going on to Alzheimer's, and similar problems there. And similarly, we don't have very many choices for people with stroke. A word about some of the proteins, and I'm going to try to wrap it up in about 5 minutes. So a word about some of the other proteins in Alzheimer's, in Huntington's, in Parkinson's. We're depositing these proteins, and we don't know if they're the cause of the effect. But we know that these abnormal protein aggregates are occurring within our brains. And two major methods of protein aggregate clearance are autophagy and microglial proteolytic enzyme secretion, and MSCs appear to enhance both of these. So what are the objectives to improving our outcomes? We want to decrease cell death, reduce scarring, regain healthy neural tissues, stimulate functional axonal regeneration, and remodel the injury. And we know these things don't engraft. There's plenty of translational studies that show benefits. Certainly microRNA play a role. MicroRNA 133b, you'll see a lot about that. That's promoting neural outgrowth. MicroRNA 121 decreases apoptosis. So what makes sense in the CNS? Well, if you look at the severity of diseases, I can make a very strong case for an intrathecal injection at C12 for areas of the brain, cervical and high thoracic, with IV, because I've just shown you that there's a correlation and there's a hardwire of the nervous system into the immune system. In the lumbar spine, we can make the case that you should do it a lumbar intrathecal injection if it's a low thoracic injury or maybe some lumbar arachnoiditis. And some of the indications for these treatments are neurodegeneration, stroke, spinal cord injury, traumatic brain injury, and the like. A less invasive means of introducing exosomes could certainly play out for some of these other indications. And I'm currently treating an autism patient in my practice with intranasal exosomes where I inject through the cribriform plate. And within 3 to 4 weeks, decrease repetitive behaviors, increasing cognitive function, and getting calls from the school, what's going on, Dad? What's going on at home? All right, so here's a case report. Craig Flinders sent me this. Craig called me in November after we were lecturing together at an ASIP course and said one of his very good friends gets a T1011 dense spinal cord lesion after a jumping injury. And not a great picture, but you can see the expanded cord lower in the thoracic spine. He said, Doug, what should I do? I said, take 3 cc's of CSF out and put 3 cc's of exosomes in. Here's his L1-2 injection. So I will tell you, this guy couldn't feel anything below the navel. He waited about 7 to 8 weeks. He injected him. Within 3 weeks, he starts feeling his thighs. And I don't know if we can run this. Can you click on the bottom near his feet? There should be a play button. Well, basically what it's showing you, this is a week after a second injection. So he's got flexion of the extension of the leg. About 2 weeks after this, he took 12 steps with a 4-point walker, which is pretty significant. And he's got adductor movement, which you can show also. But let's go to the next slide, I'm sorry. Okay, I got it. Here's another kid. This is a 19-year-old kid who had some stem cell injections as an Asia B C6 injury from 2 years before from a boating accident. He had to be carried out of his wheelchair when we brought him into my office. And this is 2.5 months after a C12 intrathecal. Click the picture on the left if you would. I don't know why that's sideways. It looks better up and down. But you get the idea. Intranasal delivery, I think, is a new frontier. It reaches the CNS via the cribriform plate. There are some contraindications, right? Well, I don't want to give you fertilizer if you've got a problem and you're already growing stuff. So I won't give it to you if you've got cancer, myeloproliferative disease, primary pulmonary hypertension. If you've got macular degeneration with neovascularization, that's wet macular degeneration, or any abnormal neovascularization, you're immunocompromised. I do some preoperative labs, and that's it. Thank you very much.